Welcome to AETCM, the Emergency Medicine Channel. As a part of EM Rapid 2024, today I am presenting topic is tricyclic antidepressant toxicity. Tricyclic antidepressants were the first generation of drugs developed to treat depression. Tricyclic antidepressants are named after their chemical structure, which consists of a rearing central structure plus a side chain plus the common type tricyclic antidepressant. Tricyclic antidepressants are now occasionally used to treat OCD, attention deficit hyperactivity disorder, panic and phobia disorder, and anxiety disorders. They possess a narrow therapeutic index, and toxicity can occur at therapeutic dose also. Tricyclic antidepressants that include antidepressant drugs that classified as reversible inhibitors of monoamine oxidase, SSRIs, SNRI, and tricyclic antidepressant. Tricyclic antidepressant divided into noradrenaline and serotonin reuptake inhibitors that contain imipramine, amitriptyline, doxepin, clomipramine, and other one is predominantly noradrenaline reuptake inhibitors that include vasopressin, nortriptyline, amoxicillin. Tricyclic antidepressants are subdivided into two categories: tertiary and secondary amines. Tertiary amines are amitriptyline, clomipramine, doxepin, imipramine, and trimipramine. They are generally more potent in blocking reuptake of serotonin compared to the blocking reuptake of norepinephrine. Secondary amines vasopressin, nortriptyline, protriptyline. They are more potent in blocking reuptake of norepinephrine. Coming to pharmacokinetics, absorption rapidly absorbed orally and nearly completely from GI tract and achieve peak plasma level between 2 and 6 hours after ingestion at therapeutic dose. Coming to distribution, they are highly bound to plasma and tissue protein, therefore they have a large volume of distribution, and they are highly lipophilic, readily cross the blood-brain barrier. Due to these properties, removal of cyclic antidepressant by hemodialysis, hemoperfusion, peritoneal dialysis, or forced dialysis is very difficult. Coming to excretion, extensive first-pass metabolism in liver by oxidation and urinary conjugation, excreted renally as well as through bile. Metabolites may have pharmacologically activity equal to the parent drug. Metabolites are excreted in urine over 1 to 2 weeks. Coming to mechanism of action, both tricyclic antidepressants they will inhibit the reuptake transportase of serotonin and noradrenaline, that receptor contained in the presynaptic nerve terminal, and that will increase the availability of noradrenaline and serotonin in the synapse. Coming to the pharmacological profile of tricyclic antidepressant, pharmacological activity is an antagonistic action of postsynaptic histamine receptors that leads to sedation and depressed consciousness. Antagonist action of postsynaptic muscarinic receptors, both central and peripheral, leads to central muscarinic agitation to delirium, confusion, amnesia, hallucination, slurred speech, ataxia, sedation, and coma. Peripheral antimuscarinic leads to dilated pupil, blood vision, tachycardia, hyperthermia, hypertension, decreased oral and bronchial secretions, dry skin, ileus, urine retention, and increased muscle tone and travel. Antagonism of postsynaptic alpha-adrenal receptors, alpha-1 receptors more than alpha-2 receptors. Alpha-1 adrenal receptors leads to sedation, neurosis, orthostatic hypotension, reflex tachycardia, alpha-2 adrenal receptors, mild hypotension. Inhibition of norepinephrine reuptake leads to agitation, mydriasis, diaphoresis, tachycardia, early hypertension. Inhibition of serotonin reuptake, sedation, mydriasis, myoclonus, hyperreflexia. Inhibition of voltage-gated sodium channel, impaired conduction, wide QRS complex, conduction abnormalities. inhibition of voltage-gated potassium channels, prolongation of QT interval, ventriculectropy, torsades depointes. Coming to toxicity, ingestion of less than 1 milligram per kg are generally non-toxic. Ingestion of more than 10 milligram per kg in adult may cause life-threatening symptoms, and fatalities are commonly associated with ingestion of more than 1 gram. Patients at higher risk for cyclic antidepressant toxicity include patients who are co-ingested with cardiotoxic or sedative hypnotic medications, and geriatric patients and patients with underlying heart or neurological disease. Desipramine is the most potent sodium channel blocker among the tricyclic antidepressants. It is able to precipitate severe cardiotoxicity, wide QRS complex hypotension, without producing significant antimuscarinic symptoms. Amoxapine, meprotylene, more toxic than other tricyclic antidepressant, especially in regard to causing seizures. Normal therapeutic level of TCA, including iron drug plus metabolite, is 75 to 80 nanograms per ml. Patients with combined plasma level of parent cyclic antidepressant and metabolites of more than 1000 nanogram per ml are great risk for developing seizures and cardiotoxicity. Clinical toxicity does not always correlate with the plasma cyclic antidepressant level. Amoxapine overdose. In this patient, this agent can cause status epilepticus without warning or QRS complex widening. According to QRS complex widening, in ECG, if a QRS complex more than 100 milliseconds, this patient it will precipitate into seizures or status epilepticus. And in ECG, if the QRS complex is more than 160 milliseconds, it will precipitate into ventricular tachycardia or ventricular fibrillation. Coming to diagnosis, by history of taking an history of exposure, clinical symptomatology, characteristic ECG findings, positive tricyclic antidepressant urine drug screen result. And sometimes it will be false positive result can occur with carbamazepine, cetirizine, cyclobenzaprine, ciprofloxacin, diphenhydramine, quetiapine, and phenothiazine. Come to characteristic ECG findings of TCA toxicity. ECG abnormalities develop within 6 hours of ingestion and typically resolve over 36 to 48 hours. The classical ECG findings leads to which are sinus tachycardia, right axis deviation of the terminal 40 millisecond in lead AVR, manifest as deep and slurred S wave in lead 1 and AVL, and an R wave in lead AVR. Normally, there is no R wave in lead AVR. In TCA toxicity, there will be terminal R wave in lead AVR. Terminal R wave, which is more than 3 millimeter in AVR. R by S ratio more than 0.7 in AVR. Prolongation of the PR interval, QRS complex, and QT interval, and Brugada-like pattern, which includes ST elevation in V1 to V3 with RBBB pattern. Prolongation of QT interval, it is due to potassium channel blockade, and sometimes we can see AV blocks. This is an ECG of TCA toxicity, which contains sinus tachycardia, widened QRS complex, and dominant terminal R wave in AVR. It's an important finding. Normally, there is no R wave in AVR lead. In disease of toxicity, there is terminal R wave in AVR. Coming to the management of TCA toxicity, like any other toxicity, we will initially manage the airway, breathing, circulation part, and will initially we will secure 2 IV lines, initiate continuous cardiac rhythm monitoring, and obtain serial ECGs and follow up the routine labs. And ABG measurement is recommended for symptomatic patients. And in TCA toxicity, patients with antimuscarinic symptoms, to prevent the urinary retention and paralytic ileus, initially we will put catheterize the patient and we insert an esogastric tube. Monitor the patient initial 6 hours. And we can do also GA contamination, but we don't use no lavage or ipex syrup. And we can give activated charcoal, like dose of 1 gram per kg, and if the patient is awake, and if the patients are arrive in our ear within 1 hour of ingestion. And coming to the main management of the TCA toxicity, we will start on sodium bicarbonate therapy. Sodium bicarbonate therapy indications are like in patients with ventricular dyslipidemia, hypotension refracted to IV fluids, QRS prolonged more than 100 milliseconds, terminal rate deviation more than 120. These are the conditions we will start from sodium bicarbonate therapy. And doses initial IV bolus of 1 to 2 milliequivalent per kg and repeat it until the patient will improvement or the endpoint of pH becomes 7.5 to 7.55. Or we can give IV infusion of sodium bicarbonate as 150 milliequivalent added to 1 liter of 5% dextrose in water and infuse at a rate of 2 to 3 ml per kg per hour. Here also we will repeat the until patient improvement or until the pH reaches 7.5 to 7.55. And we all know with sodium bicarbonate we will cause loss in potassium. So along with sodium bicarbonate, we will check for potassium and correct the potassium with KCl if required. In patients with the altered level of consciousness, we will reassurance and we can add on benzodiazepines. There is no flumazenil is indicated in mixed TCA plus benzodiazepine overdose. And also there is no physostigmine is indicated in TCA with anticholinergic overdose. And patient have seizures, we can treat with benzodiazepine like diazepam, lorazepam are the main anticonvulsant of choice to stop seizure activity. And if patient is continuously seizing and persistent, we can start on phenobarbital 10 to 15 mg per kg for the propofol infusion. Do not treat with phenytoin as it is act on sodium channel and acts on GABA receptors. And in every patient, if airway is not maintaining, then patient continues seizing, we can intubate the patient to maintain the airway and EEG monitoring if patient is continuous seizures. Hypertension we can treat it initially with isotonic crystalloid fluids in IV bolus and increments of 10 ml per kg to maximum of 30 ml per kg. We can also use vasopressors used when hypertension is unresponsive to fluids and sodium bicarbonate therapy. Norepinephrine and epinephrine are expected to be the most effective vasopressors because they directly compete with cyclic antidepressant and the alpha-adrenal receptors. Dopamine is less effective. Mechanical support of circulation with cardiopulmonary bypass, overdrive pacing, or aortic balloon pump stents may be warranted in patients with refractory hypertension. Glucagon can administered as 1 milligram IV bolus may be effective in patients with refractory tricyclic antidepressant-induced hypotension. Ventricular dyslipidemia should be treated with sodium bicarbonate. Consider 3% hypertonic saline 1 to 3 ml per kg IV over 10 minutes. Torsades deep-pointed should be treated initially with 2 grams of magnesium sulfate. Medications are contraindicated in treatment of tricyclic antidepressant-induced dyslipidemias or class 1 antiarrhythmic agents, beta blockers, calcium channel blockers, and or class 3 antiarrhythmic agents. Disposition. If asymptomatic after 6 hours, we can discharge the patient. If symptomatic, admit in ICU and we monitor the patient. When to discharge? Once patient is asymptomatic, ECG comes to normal, mental status is normal, resolution of all antimuscarinic symptoms and mental health evaluation for suicidal attempts. Thank you.